Okay. Hey everyone, thank you for joining us today. I'm just going to give it another few seconds for people to come in from the waiting room. You can see we have a big crowd today, which is great. It's a really important topic. Okay, so we're going to get started. Sorry for the minute delay. I'd like to welcome you all to this webinar on suicidality and self-harm. I just want to remind you of a few housekeeping rules. Please keep your cameras and your microphones off at all times during the presentation. And if you have questions, you can just pop them in the chat box and we'll get to them in the end. So I'd like to get started now. I'd like to thank our presenters. This is a topic that is really personal to me. I lost my daughter to suicide and anorexia 3 years ago. And my daughter had been ill with anorexia for a few years when she developed suicidality. And it really hit me like a truck because I kind of felt like after those years of learning about anorexia and how it's treated and seeing success to some degree in her treatment, all of a sudden she became suicidal. And none of her providers spoke to us about it, taught us what to do to help support her and to keep her safe. Everything that I learned about suicidality, I taught myself. And I don't want any parent to ever be in the position that I was in, where you have to teach yourself. So this is a tough topic. I know it's a hard topic, but I think it's a really important topic. I hope that if you have a child who is experiencing suicidality or self-harm, that you really walk away today with more knowledge and more skills and more information that can help you better support that child. And now I'm going to turn it over to our speakers. Thank you so much for presenting today.
Thank you, Judy. We are so glad to be here. My name is Nicole Siegfried, and I'm the Chief Clinical Officer at Lightfully Behavioral Health. And I'm my partner today is Caroline Nichols, who is the National Director of Family and Support Services at Lightfully. And we have worked in eating disorders and the overlap between suicidality and eating disorders for, gosh, Caroline, the past 15 years together. So
yes, it's been a while.
This is something that we're very passionate about and really feel honored to be able to share some things with you all today. At Lightfully, we are primary mental health, actually based on working with eating disorders. For all of those years, we saw a gap in terms of a need for people who needed care for suicidality and who really weren't able to get it. We were trying to refer people out, they couldn't get it. So we decided to become the solution in that space. And so we came on to Lightfully a couple of years ago, or developed Lightfully for that purpose. So I'm going to have Caroline share our slides. What our mission today, we've given a lot of talks about suicide. I've been to a lot of talks on suicide, and I hate the ones that use scare tactics that make you want to run screaming from the room. That is not our approach. What we know is that scaring people actually makes us avoid things more. So we're going to hopefully offer a message of hope today and a message of confidence and competence in working with clients with suicidality or your loved one who may be struggling.
Nicole, can you see the slides?
I can't.
Oh my. Okay, hold on. I don't know why it's let me figure out why.
There we go.
Okay, let me start the slideshow then. I don't know what was going on with that. Okay, now can you see?
Sure can.
Okay, perfect. All right.
I saw a note come through that this is being recorded, so just FYI, you will have access to this recording. Secondly, the first slide we want to show is a QR code that is going to give you access to the slide deck from today, and any handouts that we discuss, including the family safety plan. So if you haven't used a QR code before, I mean, you hopefully have, during COVID, when you had to do this at restaurants, it's the same here. You'll just put your phone up to this, and the flow code will come up and take you to the folder where these are stored. Also, our emails are here if you have any questions after the presentation. We'll have time for questions, but you might think of things after. Okay, next slide.
I want to make sure everybody has a chance to get that picture. Okay.
All right, so today in doing this talk for today, we were like, oh my gosh, we need 3 hours. So we are hitting some highlights today, and we were talking to Judy and Millie prior to the recording, and if you all want us to, we can come back and do another talk on some of the things that we don't get to. But here's what we're going to talk about today. We're going to first define suicidality and self-harm, debunk some of the myths around this. We're going to describe the suicidal mind, which I tell people is the most important part of really meeting your loved one where they are. Have some definitions, which includes a handout, differentiate suicidality or a suicide attempt from self-harm, and delineate suicide risks. Then the second half of the presentation, we're going to talk about the family safety plan, which is something that families can do to help keep their loved ones safe. And clinicians can use this in working with families to create safety in the home. All right, next slide. So let's start with some myths. I think it's important, first of all, to debunk myths around suicidality. First, one of the myths is that suicide is an act of cowardice. Actually, it takes someone who has a sense of fearlessness around death and a high pain tolerance to kill themselves. And so this myth can often lead us down the road of wrong interventions when we think about it in this way. And when we, hold on, some people are coming into the waiting room, so I'm just admitted them. So I don't know if there's other, Millie, if you want to admit people in. So the second myth is that individuals who die by suicide are fully intent on dying. One of the things I want to talk about with that is that a second slide on this is that most people have a sense of ambivalence leading into even the final act of killing themselves. And that's really important because that gives us a lot of room for interventions. If you'll go to the next slide for a second, Caroline, we'll come back. This is if you haven't seen The Bridge, it's a great documentary. It's an older documentary, but it follows individuals who tried to kill themselves by jumping from the Golden Gate Bridge. And Kevin Hines is one of those survivors. And he famously talks about how once he jumped, he immediately had regret. And so that ambivalence, followed him into the jump. And once he realized he didn't die, he really wanted to be saved. And he talks about, it's just actually, it always gets me choked up. He talks about how a sea lion or a seal, I can't remember which creature, but bobbed around and kept him afloat until he could be rescued. And so it's just a beautiful story. Third, this is important going into the holidays. There's a myth that suicide rates increase during the holidays, where actually the highest rate of suicide occurs during the spring in April and May. Again, not that we need to lower our radar during this time. Holidays are hard, but we don't want to think, oh gosh, the holidays have passed, this person is out of harm's way. Another myth is that the majority of people who die by suicide leave a note. That is also a myth. Only about 20% leave a note. And when they do, it doesn't necessarily answer the questions that we have that we need answered as to why this happened. Another myth is that suicide is selfish. And I think we use this to I think we use this as a way sometimes to work through some of the feelings around suicide when our loved one dies. But often when people are dying by suicide, they think that it's the least selfish thing they can do. They think they are relieving a burden to their family, their loved ones. All right, next slide. All right, so this is what I often talk about as the most important slide in understanding someone who is suicidal, because it's hard to understand. We are wired to protect ourselves, and we are wired to keep ourselves alive. And so what happens that sort of the moon, stars, and sun align that puts us in a place where the pain of dying feels less than the pain of living. And so the first thing I want families to understand is this concept of psych ache. This is a term that was coined by Ed Schneidman, who was the founder of the American Association of Suicidality. And he's put words to something that feels indescribable. I actually think it can be helpful for families to use this term. We use it as clinicians, where we say, there's actually a term for what you're experiencing. It's called psych ache. And it is the psychological pain that is behind the suicidality. Sometimes you'll see clients even putting their hands to or your loved ones putting their hands to their heads during this time, because it's a ruminative thought. It's a psychological pain, and you feel it in your head and in your heart, and it feels indescribable, but that term is a psych ache. Those who die by suicide have three factors that converge that place them at risk. This comes from Thomas Joiner's theory of the interpersonal psychological theory of suicide, which says that people who feel a sense of burdensomeness and lack connection, authentic connection, which he calls thwarted belongingness, and feel fearless around death, those factors come together to place a person at risk. In eating disorders, as we know, eating disorders have a high rate of suicide, one of the highest rates of suicide of any psychiatric disorder. Why? Why is that? When we look at what's behind the suicidality in individuals with eating disorders, what we see is this burdensomeness, this lack of connection, but most importantly, what we call an acquired capacity for lethality. And that factor is a combination of this fearlessness around death and pain tolerance. How does that happen? It's through the symptoms of the disorder. So think about your loved ones, or think about your clients. How many times do we have them saying things like, I've been told I should have died 20 times over. No one should be going around with a potassium level that low. Or they're engaging in purging, or they're engaging in restriction or overexercise. These kinds of acts against the body develop a step by step. They're acquiring this capacity for lethality and desensitizing themselves to pain and death. So that's one of the theories as to why eating disorders have this high rate of suicide. The other thing that families need to know, and clinicians for that matter, is that when someone is suicidal, they experience something called constricted thinking. Constricted thinking is something that's an adaptive function that goes awry during suicidality. So in an evolutionary approach, constricted thinking is helpful. I always say if a bear came into my door right now, I would experience constricted thinking as part of a fight or flight response, and everything would go to the periphery except the bear. And that is adaptive. That's how I would survive. In suicidality, the same thing happens where my thinking would get constricted so that all I see is dying as the option, and everything else goes to the periphery. There are no other solutions because I can't see them. I have this constricted view. So it's important for us to, outside of suicidality, talk to our clients and loved ones about this and how during that time, they're not able to see other options, other solutions because their thinking is constricted. Suicide attempts are not attention seeking, they're help seeking. This is also important to make this distinction because often, I think it's out of our own fear, we dismiss our loved ones or clients by saying, oh, she's just doing that for attention. And this may decrease our fear around it, but it also decreases our opportunity for intervention. This allows us, if we shift that narrative to these individuals see no way out, see no other way to get help, or see no other solution, it allows us to see ourselves as part of the solution, not dismissing them. We already talked about the selfishness as a myth. And so in understanding the suicidal mind, remember, these individuals are feeling burdensome. They're feeling that they will relieve that burden if they are to die. All right, next slide. One of the handouts that you have in your QR code is definitions around suicidality. For the sake of time, I'm not going to go through these one by one, but we are going to be using accessing the slides needs approval. You're exactly right. I thought about this as I was saying it. I'll do that when I stop talking and Caroline starts talking. I'll make sure that that approval it happens so you all can have access. So you'll have these definitions, and we won't go through those right now, but we will be using some of those terms. So you can go back to this if you need that glossary. Okay. One thing that's important is to make the distinction between self-harm and a suicide attempt. Many of your loved ones may be struggling with self-harm. Actually, self-harm is often a way that people manage some of their suicidality. We've had clients say things like self-harm actually takes the edge off the suicidality. It's important for us as loved ones, clinicians, to understand the difference between someone who's actually making a suicide attempt and who's self-harming, because the response should be different. For self-harm, the intent behind it is to manage difficult emotions. For a suicide attempt, the intent behind it is to die. We don't always need to, we'll talk about this with the family safety plan, but we don't necessarily need to respond to this in terms of a suicide attempt when it is self-harm. It may be an overreaction to the self-harm. Now, at the same time, we don't want to minimize it, knowing that self-harm, to achieve the same effect, you develop a tolerance and you're upping the ante every time you do it. And so one of the things that can sometimes happen is an unintentional death based on the increased lethality of self-harm. So we definitely want to make sure we're intervening for self-harm, but we don't want to respond to it as a suicide attempt. That is a mistake we often make, and we'll talk about that in the safety plan. All right, next slide. So we're going to be spending the majority of, or the next half of the presentation on the family safety plan. we're going to talk about these different risk level designations. As clinicians, we use these designations. We've made the distinction and the separation of high risk into two categories, which is elevated risk and imminent risk. For imminent risk, the intervention there is hospitalization because individuals with imminent risk are unable to achieve safety. Elevated risk, you may have ideation, plan, intent, but you're also able to create safety. And so individuals with elevated risk are often able to be managed at an outpatient level. We don't need to hospitalize those individuals. So we'll talk about ways that families are able to do that. Moderate risk, these individuals may have suicidal ideation, which is thoughts. They may have a plan, but it's a loose plan, but they don't have intent. They have what we call protective factors, which are just as important as risk factors at these lower levels. These are things like, hey, I might have this risk factor of an eating disorder, let's say, but I also have a protective factor, which is that I have good supports through my family. And so those things can kind of offset each other at these lower levels. Low risk is where there isn't ideation or plan or intent. Something that we are really emphasize is that even in low risk, we need to plan for the possibility of escalation, and we need to have a de-escalation plan in place in case risk does develop over time. So you can see here the clinical interventions that teams are trained on in working with clients who are suicidal. We're going to talk through a family safety plan that corresponds to these clinical interventions. So I'll pass the baton to Caroline. And while I do that, I'm going to also give permission to the slide, the QR code. I apologize for that.
Awesome. Thanks so much, Nicole. And thank you guys so much for having us. This is a really difficult topic. Certainly as we enter the holiday season, there is nothing holly and jolly about this topic, but it's such an important one. So we really appreciate your time and really encourage you to take care of yourselves, as we go through the rest of this and for the rest of the day, week, all of those kinds of good things. So, all right. So the family safety plan was something that we created to provide some structure and containment for families and their loved ones to be able to have conversations that they otherwise might not feel comfortable having around suicide, warning signs, risk factors, things like that. We also created it as a way for families to have very tangible ways of supporting their loved one. So often as parents, we are trying all the things to support our loved ones, our kiddos, our adult children, whatever it may be. And sometimes those feel really effective and sometimes they just don't. And unless we have the information from our loved ones of like, hey, this is not helpful, but this would be, it can lead to a very frustrating place for families. I'm like, I'm doing all the things that I've been told to do and nothing seems to be really working. So those were the primary reasons we created this family safety plan. So what we sort of did was take these more clinical risk levels, and you guys can actually follow along if Nicole, once Nicole gets the permissions set, you will have actually a copy of our family safety plan that you can kind of follow along with, because unfortunately I won't be able to go over all of it, but we're going to hit some of the high points. So we took these more clinical risk levels and sort of broke them down and using this thermometer because it just can be a lot easier for clients and for families to talk about this. Recently, was working with a client who was experiencing high levels of suicidality and was able to tell his parents, I'm in the red stage. And therefore they knew exactly what they needed to do. So it provides an opportunity for very quick communication. So you can see that our red stage, and actually I'm going to start with the green stage down at the bottom. So green stage, which is low or no risk, is going to represent behaviors, thoughts, and feelings around normal everyday stressors and situations that might keep us moving closer to recovery. As we go up the thermometer, we get to yellow, which is that moderate risk level. And that is just going to represent an intensity of green behaviors, thoughts, and feelings, making it more difficult to solve problems or ask for help. In our orange stage, we have an increase of yellow behaviors, and this would indicate that your loved one is at an elevated risk for a suicidal crisis, okay? And then a red stage mirrors our imminent stage, so this is an increase in those orange behaviors, indicating that there is imminent risk of safety to self or others. And so we're going to kind of use this thermometer as our basis for working through the family safety plan. Now, you might also be asking, what's a family safety plan? Hopefully some of you guys have worked on these, but for those of you who are not familiar, the best way I can sort of describe this is it's like a family playbook of the best ways to minimize or divert a suicidal crisis. This is something that gets created collaboratively with your loved one, you, and a therapist or a member of the treatment team, again, so that we can, you'll see as we sort of talk about some of this, that the questions can be a little bit difficult sometimes. And so having a therapist, could certainly do this on your own, but having a therapist or somebody familiar with your loved one, with the family dynamic, can certainly help fill in some of those gaps and these questions that are hard to answer, and kind of this subject that's very difficult to talk about. And we like to think of the development and implementation of a family safety plan as preventative. It's just like wearing a seatbelt. So we use this family safety plan regardless of suicidal history, current suicidal risk level. I mean, everybody, every client that we work with does a family safety plan. So as we go into it, there's some various components that I just want to check out. You'll see if you're following along in the family safety plan, there's some psychoeducation there in the beginning. There's sort of psychoeducation peppered throughout. But just to, we talk a little bit about what is a suicidal crisis, what is a mental health crisis, and then there's a chart with all the beautiful risk levels. But the primary components of the family safety plan are, number one, a F.E.A.S.T sheet. This just contains really important information for you to display in your home. It has everything all there right together, which can be very helpful, especially like if you are the parent of a teen or an adolescent that's still living at home, but maybe spends time at, grandparents' house or, somewhere else. You could make copies of this for those individuals to have as well. There's an actual safety plan piece of this that focuses primarily on safety. So this is going to help support your family in clearly identifying the actionable steps that you're going to take to ensure that your home environment is safe. Then we're going to go through the stages of a suicidal crisis. So again, we're going to be looking at, and these are all on your definition page, but activators, warning signs, thoughts, feelings, behaviors present at each one of these stages. And it also is going to provide an opportunity to identify very tangible ways that you can support your loved one and that they can ask for help from you. And then the back of the safety plan has some helpful tips, a little bit more psychoeducation around guns and weapons and medication safety. There's some reminders, and then there's a list of links to websites, podcasts, apps for your phone, things like that. And so what we want to remind you is, and this kind of might go against some of what we hear societally about, hopefully we're working to dispel this myth that we shouldn't be talking about suicide, that would make somebody act on it, when we actually know that talking about suicide and providing open communication around this topic will actually reduce the likelihood of an attempt. So understanding your loved one's mental health experience, their activators, their warning signs, and ways to support them is going to increase your confidence in knowing that you can effectively support them and help mitigate a suicidal crisis. So I want you to just kind of keep that in the back of your mind. All right. So you can see this face sheet really goes through like, what is the primary diagnosis? What are the medications? It's going to give you a place to list names and phone numbers for pharmacists, pediatricians, internists, family therapists, dietitian, all of those different providers that your loved one might be utilizing or that you might be utilizing. So there's a place in there for local hospitals, other support. So that might be family friends or other family members. Poison control is on there, the suicide and mental health support lifeline. There's a spot for you to put your local psychiatric emergency response team. I know that varies by state. Local mental health crisis name and number, again, varies by state. And then there's a little checklist at the bottom, sort of identifying that, yes, we have done all of the things we said we were going to do to maintain safety with regard to weapons, medications, things like that. So then we're really going to be looking at creating a safe environment. And this is really important and can be really activating sometimes when we're asking families to maybe get rid of guns for a time, or, lock up medications. I mean, these things, and we don't believe that the response is out of non-concern. But we're asking you to do a lot. Those are not always very convenient things to do. But we certainly want to encourage people to identify safe and secure storage for any kind of weapon. Limit access. So one person has access keys or combinations. Sometimes it's going to be important, imperative, critical just to remove those items from the home. I wouldn't say it's necessarily for forever, but we also know that, and this is in the actual family safety plan. I think it's that in homes where guns are present, the risk of suicide is like 3 times higher, and the risk of homicide is about 4 times higher. And that's not just for homes where suicidal ideation that we're aware of. So again, this can just be a really important thing. And then you want to be able to post all of that really important information so that if there is a crisis, there's one place to go to make those phone calls for that help. We also want to be encouraging families to really look at other safety concerns. This can get a little bit tricky because we're certainly not advocating for families to set up a residential type living environment for your loved ones. There's just something about that never ends well. If you guys have tried that, you get a lot of pushback because as humans, we want autonomy, and that feels like maybe we're suffocating. And it is a very normal response for a scared, terrified family member to want to just remove everything. So, if your kiddo or your loved one is somebody that might self-harm, these would be really important things to think about. So it might be that if they self-harm with razors, that there's a process by which maybe they decide that it would be safer for them to keep their razor in your bathroom, and when they need it, a few times a week, whatever, that they ask for it. So there, and what we're able to do to get creative around what's going to help each individual person is really great in this, because it's not going to be cookie cutter for every family. But these are things that we want to be kind of aware of. So we're also going to be looking at suicide risk factors. And if you have been able to access your definitions, you know that risk factors for suicide can really be described as situations or experiences that might increase a person's potential for suicide or suicidal behavior. This is not an exhaustive list by any means. And so the thing that I really love about having this in this family safety plan, and within some of what we're going to be looking at, there's a really great opportunity for your loved one to be able to communicate to you what are their risk factors. Because it would probably be rare that somebody would have like all of these different risk factors. And so it's really important to understand from their perspective, what are their risk factors? And there's likely other risk factors that are not listed here. So it really creates an opportunity to be able to talk about that and for families to be very curious about what their loved one's experience is. Same thing with suicidal crisis activators. And so again, activators, so one thing that's important to note, activators might also end up being risk factors. Like if you had like a recent loss, that's on both slides, but it's important to remember that not all risk factors are activators. Okay. We have this sort of sectioned out by there can be some home or environmental activators that usually includes like some relational dynamics. We could probably expand this and make it huge. There's some school or work activators to mounting pressures, anxieties about deadlines at school, work, grades, that kind of thing. And then there's other activators like medication changes or community trauma or violence, some of those types of things. So again, these are just situations and stressors that might activate a mental health crisis or a decline in mental health that might indicate a pending suicidal crisis. And again, this is not an exhaustive list. We also really want to have some good conversations about warning signs. Again, this is just to kind of get us thinking. This is not an exhaustive list, but we know that folks that might be thinking about suicide might be talking more about suicide or just death in general. They might start to give hints that they might not be around anymore. They might start giving away possessions or sort of parceling out their belongings. Likely going to be experiencing a lot of feelings of hopelessness, burdensome, as Nicole mentioned earlier. We might start to see some notable changes in mood. Interestingly enough, it is also true that does not that's not specific to depressed mood. Sometimes we see people that seem like, oh my gosh, they're doing so much better. Like, so it's important that we're not lulled into safety if we have a loved one that really struggles with suicidal ideation, that we get curious about that and not just take it as like, oh my gosh, they're so much better, because oftentimes there is sort of that burst of energy, or Nicole, you might have another word for it, that kind of can happen before somebody will make an attempt.
Yeah.
Mm-hmm. So again, we might see them losing interest in school, sports, that kind of thing. But again, this also gives your loved one an opportunity to talk to you about what happens for them. As Nicole says, to kind of understand the suicidal mind, it's very difficult, because if you've never struggled with suicidal ideation before, you're probably not going to completely understand it. That's okay. But it's really important to maintain that level of curiosity around, what is this experience like for you? Help me understand it so that I can support you. The other thing that might be really important as we think about warning signs, risk factors, or activators, is that they may not make sense to us, and that's okay. We kind of have to get comfortable with that and accept it for what it is their experience. And then if we want to ask questions, stay rooted in curiosity. And that request, like, I really want to understand what's happening for you, because I can imagine that is so incredibly terrifying. Okay, so those are warning signs. You're also going to see that the bulk of the family safety plan is really going to be breaking down each of the different stages. So we're going to start with green, and it's really important, and this might feel very counterintuitive to those of you who have loved ones that sort of exist in maybe some of these upper levels of suicidal ideation. Or if that's really, really present with your loved one, it might be hard to go. You might be going, Caroline, I don't want to start with green. I want to start with what's going on right now. it's really important to start with green, because the more we understand what this process is for your loved one, and really the more they understand it, the more opportunity we have to intervene and reduce the likelihood that those green or low risk, that low risk stage is going to escalate to yellow, orange, or red. So it's really important not to miss this step. And that can be really, really difficult when things feel more pressing, like to get to those upper levels. So in each level or each stage of sort of the suicidal crisis, we're going to have the client, your loved one, start to really identify behaviors, thoughts, and feelings that are present within each level. We also want them to be looking at what are some of the activators and warning signs for those behaviors, thoughts, and feelings. Okay. So it might be I start thinking about self-harm, right? Or I start thinking about how much better my family would be if I just weren't around. Or I start thinking about how much money my family has spent on treatment, and then I start to feel really guilty. We also want your loved ones to explain to you as best they can how you will know if they are experiencing those identified behaviors, thoughts, and feelings. What will that look like externally? What will the change in mood look like? Will they, perhaps start pulling away and not wanting to do family activities or participate in after school events, or start to disconnect from their friends? What will the family notice if I start to feel guilty about how much money my parents have spent? What is that going to look like? And keep in mind that this can be very, very scary for your loved ones, because we're sort of asking them to tell on themselves, right? Like to share sort of the intimate details of what's happening for them, knowing full well that the reason we're doing this is so that somebody can intervene. And that can be really difficult, because a lot of your loved ones might really hold on to their suicidal ideation as something that allows them to get through the day or through the moment. We're also going to be looking at safety concerns, identifying ways that your loved one can ask for help at each stage, and ways that the family can tangibly support the loved one in staying safe. And so this is a really cool thing, and it sort of mitigates that guesswork that a lot of times we're forced to do as families, of like, I don't really know, but I'm going to try this, or I'm going to try this. And then there's a family plan for managing each stage. So, when my loved one, or when our loved one is in the orange stage, what is our family plan to manage the safety concerns? Like, what is the thing that we're going to do in this stage to prevent continued escalation and get them the help that they really need? And after we do all of that, this is just a reminder. So when you have a mental health or suicidal crisis, you're going to want to assess the situation. Are they in danger of hurting themselves? Do you need emergency assistance? Do you have time to start with a phone call, or do you need to go straight to somebody who can help more quickly? You're going to seek help. So based on your assessment, you're going to seek help from the appropriate system. You're also going to have the tangible plan for each level of care. So there might be other things that you would add to this. And then you're going to want to use de-escalation techniques. And this is where I think Nicole and I could come back and do a whole presentation on some of these de-escalation techniques. The thing that I would say the most, which is probably the hardest to do, is to stay calm. Many times, if we get our nervous systems will connect and intertwine with our loved ones' nervous systems. And so if we get really escalated and panicked, which would be a very normal reaction, that might prevent them from saying any more, because they don't want to see you distressed. It might continue to escalate them. So we, of all of these things, I would say, like, stay as calm as you possibly can. And then at any time, if your loved one is in immediate danger, call 911, hospitalization, emergency room, those kinds of things. All right, I'm realizing that we are headed to time. So I'm going to stop sharing. And
Caroline, can you bring back the QR code so they can,
yes, I
now
certainly
that they have
can.
access?
Yes, I certainly can. Let me get this up and can you guys see that?
Yeah,
You can?
yeah.
Yes.
Okay, good. Okay, good. Good.
Okay, so I'm waiting for the questions to come in, but I'll start with one,
Okay.
which is, talking about the assessment, and the different colors. As a parent, how do you have a conversation with your child? Meaning, you think that they're somewhere in that, traffic light. You're not exactly sure where they fall. You're seeing some of the symptoms or the signs on that list that you gave. How do you approach that? What kind of conversation do you have so that you can then make some type of parental assessment of where they fall out on, that scale?
Yeah. I get this question a lot, and I get it from parents, and I also get it from the clinicians that we work with. And what I typically resort to is, I would just have a very direct, lovingly direct conversation around, and that's why it can be helpful to develop language around the suicidal, like the stages and sort of what that looks like. So that you can very directly say, like, it seems like you are struggling right now. Can you tell me what color you are? Or, can you tell me sort of what's going on? And then you might say something like, it seems like you're in that yellow stage. Does that fit? And then they can say, no, I actually feel like I'm in the orange stage. So developing language around like how we're going to talk about it. I very often would tell parents in the support group I used to run, especially if your kiddo is seeing a therapist, like it's a great conversation to have of like, I'm learning about this, what this experience is like for you. And I'm really interested in understanding what it's like for you. And so can we even talk about how we're going to talk about it that feels safe for you, and that allows us to exchange information in a way that allows me to really step in and support you. And so that's always my go-to. Nicole, you might have something you want to add to that.
I would just reiterate, as clinicians or as loved ones, the recommendation always is to ask the direct question. Are you having thoughts of hurting yourself or killing yourself? We know that asking that question does not plant that as an option, like, oh no, I'd never thought about that, but now I am. That's not what's going to happen. There's no evidence of that. So asking that directly, and then be prepared for the answer. So when they answer, yes, I am, then following that up with, we use EFFT. If some of you may be familiar with emotion focused family therapy, we use EFFT validation scripts. That's what we want to come back and help train you all on. Some of you may, if you're using FBT with your loved one, you may be using EFFT. I'm using all of these acronyms, I'm so sorry. But what we do with an EFFT validation script, we don't try to solve the problem from the get-go. We validate first. And so we validate, and that feels very hard to do with suicidality, because it feels like we're saying, well, I agree, you should kill yourself. That's not what it is. We're validating the pain behind it. So using the script of, I can imagine, Caroline always corrects me, you know how I always start my script wrong. But that
we would validate hopelessness in this case.
Yes.
But it's hard because we might say something like, I can imagine that the only solution that feels right to you is for you to end your life.
Yes.
That's a very, very difficult thing for any parent to say, for all the very, very obvious reasons. But yeah, I would echo Nicole, just very direct conversations, having some language around it, communicating, validating. Yeah.
Thank you. Next question. Does self-harm lead to suicidal thoughts?
This is a great question. And actually, it doesn't lead to suicidal thoughts. So let me start there. In fact, there's evidence that it might, what's the word I want? Dissolve or soften suicidal thoughts. That seems strange, doesn't it? But it's a method of de-escalation. And so often when those thoughts are very heightened, self-harm, I'm not recommending it as an intervention, but self-harm often softens that. Now, so it doesn't lead to suicidal thoughts. However, I always think about the acquired capacity for lethality as a bucket. Self-harm is adding events to that bucket. Every time your loved one self-harms, they are adding experiences that increase their capacity for lethality. So it doesn't lead to thoughts, but it does increase their risk for suicide, if I'm making sense there, because it's increasing their pain tolerance and increasing their fearlessness around death.
Okay, thank you. Someone wants to know, is there a separate treatment for suicidality? Which is a great question, because the whole issue of comorbidity in eating disorders is so complicated, and so frustrating for parents, because many times, it's not just one, issue, it's multiple issues, and suicidality and eating disorders are intertwined, and yet in my experience, they're rarely treated together. So I'll let you answer the original question, which is there a separate treatment for suicidality?
Well, our recommendation, the answer to that is yes. Our recommendation, sort of what you're saying, Judy, is integrating. There's all of these separate treatments at this point. There's over 100 different evidence-based treatments. And so we don't want go to this therapist for suicidality and that therapist for your eating disorder and that therapist for your OCD. We really want to be able to integrate those into one treatment. And the treatment that we utilize is the CAMS approach, which stands for the collaborative approach in management to suicidality. It's David Job's approach. And it really looks at the drivers behind suicide and addresses those as part of treatment. We also integrate from other evidence-based interventions like DBT, for instance, which was also developed with suicidality as one of the main areas of focus. So yes, the answer is there are interventions specific to suicidality. And I love the question because in the past, probably 20 years ago or so, we didn't see suicidality as a separate treatment. We saw it as something that would improve when you treated other disorders, so to speak. So there was this idea, well, we'll just treat the depression and the suicidality will dissipate, or we'll just treat the eating disorder. And that's not true. We have to treat the suicidality directly.
And if I could add into that, like as we think about those of you who might have loved ones that are not in higher levels of care, so maybe you're utilizing an outpatient therapist. I think the thing that I would tell any family member is it's going to be very, very important to, if your loved one struggles with suicidality, to find a therapist that is comfortable treating suicidality and is comfortable talking about suicidality. That's not going to be every therapist, and that's okay. But if this is something that your family is really struggling with, then it's going to be really, really important that you have a therapist that is not afraid to go to these places and have these conversations with your loved one and with the family. So.
Okay, thank you. The questions are flying faster than I can read. So, is it recommended to psychoeducate the person with the eating disorder about the bucket you told us about? Make them aware of self-harm increases suicidality. And I guess just how much do you psychoeducate? How much do you share?
Yes, this is part of the lovingly direct aspect that Caroline was talking about. This isn't a secret. We want our, depending on age. I mean, as long as it's age appropriate, but we want the client to be part of this, and so to understand their risk level, not in a finger wagging way of like every time you self-harm you're increasing your risk for dying by suicide, but as part of them understanding their overall risk, that self-harm in the moment may be something that's helpful, but it might have consequences that are on the other side of it that are not so helpful.
Mhm.
Thank you. Unfortunately, we are pretty much out of time. I want to really say thank you. Suicidality and self-harm is a topic that many providers don't want to talk about, much less treat. And the fact that you do treat it, as a parent, I really want to say thank you. I know that there is liability involved. I know that there is an uncomfortable feeling involved. But for parents, it's terrifying to know that your child has suicidality and you can't find someone willing to treat that. So, really heartfelt thank you to both of you for being here today and for sharing all this with us. I definitely want a follow-up, so we'll talk about that going forward, because the de-escalation, I know it was too much to fit into one webinar, but I think de-escalation tips would be super helpful for parents, so we have to figure out a way to do that. And now I need my end slides, please. There are slides. All right, I'll just talk. So thank you, everyone, for being with us today. As many of you know, we are in the middle of our end of year fundraising campaign. All of the programs and services that we provide are free of charge, and they're funded largely by the generosity of our F.E.A.S.T community. So if you can help, if you can give a donation, it will help keep programs like this webinar free and accessible for everyone in the future. Next slide. Okay. Our next month's webinar is Treating OCD and Eating Disorders by Dr. Sherry Levinson. I think this is a really important topic. I know a lot of parents experience this comorbidity. I've heard her speak about it. She's amazing, which is why I asked her to present to F.E.A.S.T. So put it on your calendar, register. You won't want to miss it. And I just want to talk for a second about F.E.A.S.T of Knowledge. F.E.A.S.T of Knowledge is going to take place on February 4th of 2024. It is an amazing educational event. It is a one-day educational event dedicated really to information that parents need to know. If you are a parent, if you are a clinician, it doesn't matter. You will learn a ton from coming to this event. We have concurrent sessions, some of which you'll be able to go to live, some of which you'll watch afterwards. If it's in a different time zone or you can't make it, everything is recorded. You can go to the digital library afterwards and watch it at your leisure. But really, it's an amazing program. It's a great lineup of speakers, and I encourage you to register today for this. It's on our website. There is a registration fee involved, but at F.E.A.S.T, we believe that no one should be denied access because they can't afford something. So there are scholarships available. Nobody will be denied if they can't pay the registration fee. So all the information is on our website. Please go and take a look and register today. And I want to thank you all again for attending. I want to thank our amazing presenters, and we will see you all next month.
Thank you all so much for
Thank you
having
so
us.
much.
Take care. Take care of yourselves.
Bye.
Bye.